Welcome to this immersive journey into the world of glomerular filtration rate, the gold standard marker of kidney function. From the microscopic magic of nephron filtration to the clinical clues GFR offers, we are about to dissect the science like never before. GFR isn't just a number, it's the physiological pulse of your kidneys. Stay tuned as we explore how this vital function is measured, modulated, and medically interpreted. Let's dive with EasyPhysiology and ResearchPro into this renal marvel that defines life-sustaining filtration. By the end of this video, you'll be able to define GFR with precision, understand its physiological foundations, and identify the dynamic factors that shape it. We'll uncover how to measure and estimate GFR using gold standard and bedside methods. Finally, we'll apply GFR knowledge to clinical decision-making in acute and chronic renal disorders. These aren't just theoretical concepts, they're clinically transformative tools. So, let's sharpen that scientific lens and get started. GFR is the volume of plasma filtered per minute by all functioning glomeruli in both kidneys. Expressed in milliliters per minute, it's standardized to body surface area, typically 1.73 square meters. In healthy adults, GFR ranges from 90 to 120 milliliters, average 125 milliliters per minute per 1.73 square meters. It directly reflects the kidney's filtering capacity and serves as an early marker of renal impairment. Remember, GFR is not static. It varies with age, sex, and physiological conditions. At the heart of GFR lies the renal corpuscle, composed of the glomerulus and Bowman's capsule. This tiny but mighty structure is where blood plasma transforms into filtrate. Under the microscope, we see a beautifully orchestrated interaction of capillaries and filtration surfaces. Blood enters through the afferent arteriole, and filtration occurs across specialized layers. This is the birthplace of urine, where homeostasis begins. The three-layered filtration barrier is a masterclass in selectivity. The fenestrated endothelium allows solutes but blocks cells. The negatively charged basement membrane repels proteins. Podocytes wrap the glomerular capillaries, creating fine filtration slits. Together, these layers allow water, electrolytes, and small molecules to pass while keeping out the cellular and proteinaceous components. A marvel of molecular filtration indeed. Ultrafiltration is governed by Starling's forces, a balance of hydrostatic and oncotic pressures. PGC, or glomerular capillary pressure, favors filtration, while PBS and oncotic pressure resist it. Net filtration pressure is the final driving force, usually around 10 mm of mercury. This interplay dictates how much plasma gets filtered into Bowman's space. Understanding these forces is essential to grasp the dynamics of GFR. Multiple forces shape GFR. Glomerular hydrostatic pressure drives filtration, while Bowman's capsule pressure and plasma oncotic pressure oppose it. The filtration coefficient, or KF, reflects surface area and permeability of the capillary bed. Even minor shifts in these variables can significantly impact GFR. It's a finely tuned system where small physiological nudges create big filtration changes. Despite daily fluctuations in blood pressure, GFR remains astonishingly stable. This is thanks to renal autoregulation, which kicks in between 80 to 180 mm of mercury. The myogenic response adjusts vascular tone, and the tubuloglomerular feedback loop fine-tunes it via macula densa sensed sodium chloride levels. It's a built-in buffer to prevent GFR swings and protect nephron integrity. The kidney listens to hormones. Angiotensin II selectively constricts the efferent arteriole, preserving GFR during low perfusion. ANP dilates the afferent arteriole to offload excess volume. Sympathetic nerves clamp down on both arterioles during stress. These hormonal checks and balances maintain homeostasis in dynamic physiological states. The endocrine renal symphony is real. Inulin clearance is the gold standard, freely filtered, neither secreted nor reabsorbed. The classic clearance formula, urine concentration multiplied by volume divided by plasma concentration, gives us the GFR. It is accurate but complex, requiring steady infusions and meticulous sample collection. This makes it more of a research tool than a clinical staple. Nonetheless, it's the benchmark against which other methods are validated. In clinics, we rely on creatinine, an endogenous muscle-derived marker. It's produced at a fairly constant rate and inversely mirrors GFR. Creatinine clearance over 24 hours is a practical method, though tubular secretion overestimates GFR slightly. Its ease of use often trumps its flaws. But accuracy depends on proper collection and individual characteristics. We now estimate GFR using equations like MDRD, CKD-EPI, and Schwartz, factoring in creatinine, age, gender, and race. CKD-EPI outperforms MDRD at higher GFR values. Schwartz is pediatric specific, while Cockcroft-Gault assists in drug dosing. These tools have revolutionized renal diagnostics and management. Clinical nephrology today stands on the shoulders of these equations. GFR greater than 90 is usually normal unless there's kidney damage. 60 to 89 may indicate mild dysfunction or age-related decline. A drop below 60 flags chronic kidney disease, CKD. Below 15 signals end-stage renal disease, ESRD. Accurate staging helps guide therapy, predict outcomes, and allocate resources wisely. GFR is a sentinel in both acute kidney injury and chronic kidney disease. AKI is an abrupt drop, often reversible with timely intervention. CKD creeps in gradually but often irreversibly, unless progression is slowed. Reduced GFR impacts drug clearance and is a strong predictor of mortality. Monitoring GFR in chronic illness is not optional, it's life-saving. GFR naturally declines after age 30, at around 0.75 to 1 milliliter per minute per year. Men usually show higher GFR due to muscle mass and hormonal differences. This decline is physiological but accelerates in disease states. Age and sex are vital considerations when interpreting GFR. Context always matters. Proteinuria often shows up before GFR drops. Microalbuminuria signals glomerular damage at levels as low as 30 mg per day. Nephrotic range proteinuria exceeds 3.5 grams per day and screams severe pathology. Protein in urine is the red flag waving before full-blown GFR collapse. Always chase unexplained proteinuria with renal workup. Under physiological factors, hydration status, protein intake, exercise, posture, all tweak GFR subtly. Under pharmacological influence, drugs like NSAIDs and ACE inhibitors have significant effects on renal perfusion and filtration. Pathological influencers include diabetes, hypertension, and glomerular diseases. GFR is dynamic and context-sensitive, never interpreted in isolation. GFR dictates how we dose nephrotoxic and renally cleared drugs. Aminoglycosides, digoxin, morphine, each needs tailored dosing in CKD. Overdosing leads to toxicity, while underdosing risks failure. GFR bridges the gap between pharmacology and physiology. Every prescription in renal patients begins with a GFR check. Let us bring theory to life with a compelling clinical scenario. Meet Mr. Rahim, a 55-year-old male with a long-standing history of poorly controlled type 2 diabetes and hypertension, two of the most notorious culprits in chronic kidney disease. He walks into the clinic complaining of persistent fatigue, mild ankle edema, and an unexplained reduction in urine output over the past few weeks. His laboratory findings paint a concerning picture. Serum creatinine levels have crept up to 1.8 mg per deciliter, well above the normal range for his age and body mass. The estimated glomerular filtration rate, eGFR, calculated using the CKD-EPI equation, clocks in at 42 milliliters per minute per 1.73 square meters, firmly placing him in stage 3 ACKD. Adding to the diagnostic weight, his urine albumin to creatinine ratio is 800 mg per gram, indicative of significant albuminuria and ongoing glomerular injury. This is not just a number game. This is progressive nephron loss in real time. And it demands urgent, targeted intervention. First, optimize his blood pressure with an ACE inhibitor or ARB, not just to reduce hypertension, but also to confer renoprotective benefits by reducing intraglomerular pressure. Next, reassess and recalibrate his anti-diabetic regimen to avoid nephrotoxic agents like metformin, especially as GFR dips below 45. Nutritional counseling becomes pivotal. Advise sodium restriction to control fluid retention, and moderate protein intake to reduce nitrogenous waste load. Importantly, schedule GFR monitoring every 3 months, watching closely for declining trends. This case exemplifies how interpreting GFR in clinical context is not only diagnostic, it's prognostic and therapeutic. GFR isn't just a number, it is a roadmap for renal rescue. GFR is more than a number, it is a physiological lifeline. It integrates glomerular architecture, vascular dynamics, and hormonal cues. Estimation tools like eGFR make clinical decisions faster and smarter. But always monitor trends, not just snapshots. The kidney whispers before it screams. Listen to GFR. Subscribe EasyPhysiology and ResearchPro for more discussions in physiology.